Morning. Okay, so today we're going to do two of the extrapyramidal systems. Extrapyramidal meaning they have to do with motor, but they're not the pyramids, they're not the corticospinal pathways. These are in fact the cerebellum and the basal ganglia. Now, for both of these topics, I have to tell you that there's a lot of potential information here. But I want to distill it down to what's clinically relevant and what you really need to know, and not get bogged down in some of the really crazy neuroanatomy that's associated with both of these structures. Okay, this is a really great review schematic, right? Because there are lots of words on here now that you definitely should have some idea about. So, why don't we just go through at the top and see how we do as a little review. So, cerebral aqueduct. So that is the small passageway, right, between the third and the fourth ventricle that passes through the midbrain. There's the midbrain tectum, or the roof of the midbrain. That tentorium cerebelli, the part of the dura mater that extends over the cerebellum. And if I were to ask you now what cortical material you find immediately on the other side right here, that would be the occipital lobe, right? And the only tissue you're responsible for in the occipital lobe is the primary visual cortex. So this is all about cerebellum. These are some, when you see really crazy things, like this is one of Dr. Johnson's favorite things, the torcula of Aeropolis, so he loves that one, I don't know why. That's actually more the confluence of the sinuses, the venous sinuses. Foramen magnum, that's that large opening in the cranium itself that allows for the passage of the spinal cord. And so here we have our levels of the brainstem we did yesterday, right? The medulla, both caudal and rostral. And then we have the pons, and then we have the midbrain up here, pons and the medulla. And we know that passing through here are what? 3 long pathways. We have 10 of the 12 cranial nerves. And we also have that reticular formation, where we have a caudal the rostral aspect is more for alertness, awareness, and the caudal aspect is more for autonomic things like cardiovascular, respiratory. So that's a sagittal view, right? So you know the fact that the nose is over here, and the back of the head is over there. This is the pituitary sitting in this little bony process called the sella turcica. Yeah, so that's a good review slide. So we're today doing this large structure here, the cerebellum, that develops embryologically with the pons. The cerebellum is not part of the brain stem, but more develops embryologically with the pons, and we're going to see how these two structures are intimately connected with each other. So what is the cerebellum all about? So if we think about the outflow of motor activity, the cerebellum does something that we as humans and plenty other mammals rely on quite a bit, and that's to coordinate smooth, ongoing movements. So when the analogy, the other day when I'm talking about picking up the coffee cup, we take it for granted about how smooth our limbs, like our arm, moves, and with such purposeness as how it picks something up and brings it back, and we're able to drink out of a cup. So the cerebellum is a critical structure about this fluidity of movement, and it's really testing what's going on by moment basis with motor activity. Now, it's kind of curious because it doesn't project to the spinal cord. It receives spinal cord information about sensory information, but it doesn't actually affect motor neurons in the spinal cord. So how does it do this? Well, really, it's affecting the cerebral cortex, which we know is responsible for that outflow of motor activity. So the cerebellum does not influence the bulbar or spinal neurons directly. Rather, indirectly influences the cerebral cortex. And look what pathway it works to actually mediate effect through: the thalamus. So the thalamus is again coming up now, is relaying information from the cerebellum to the cerebral cortex about ongoing movements. So how do we know the cerebellum is critical for motor activity? Well, lesions of the cerebellum result in irregular, uncoordinated movement, which collectively is referred to as ataxia. So ataxia, when you actually hear that term, will always be applied to something wrong with the cerebellum. So ataxia is about irregular, uncoordinated movements, and they're always associated with the cerebellum. So here we have a structure in the brain critical for motor activity, and yet doesn't influence those spinal or bulbar motor neurons. Rather, it influences the thalamus, which then conveys that activity, that regulatory activity, onto the cerebral cortex, and specifically the motor cortex, to affect that ongoing activity. So again, we're talking about things that are happening on a millisecond by millisecond basis, right? So it's something very, very fast, but clearly very important. Now, this is what makes the cerebellum important for you clinically. And this is really, I think if you get these 3 points here, this is really the crux of the cerebellum from a clinical point of view. So we know the fact that every pathway we've done so far has this idea of crossing, right? The really important ones. So corticospinal, lateral corticospinal, really important. Information starts on the right, influences the left. Sensory information from the left ends up in the right cerebral hemisphere. So we've got this idea of crossing. And it turns out that the same is true for the cerebellar pathways, but ataxia gives rise to ipsilateral lesions. So where you actually have the uncoordinated limb is ipsilateral to the side of the cerebellar lesion. So that means what? That there's no crossing of the information? In fact, the information crosses the midline and then crosses back. And so cerebellar lesions, and this is critical from a clinical point of view, cerebellar lesions give rise to ipsilateral ataxia. And it's not because this is an ipsilateral pathway, it's because that the cerebellar information crosses the midline once and then crosses the midline yet again, which means it goes from right to left and from left back to right, and that's why you get an ipsilateral presentation. Critical. Now there are two types of ataxia. There is a truncal ataxia. We've done, right, the truncal aspect of motor activity. And that was anterior cortical spinal, right? Where anterior cortical spinal is really influencing things in the midline. And you get that bifurcation of the axons, right? The level of the spinal cord influencing both left and right to keep you upright, right? So that you have wonderful symmetry of your shoulders and your hips. You don't need symmetry between your two arms, right? Or between your two legs. So we've done about this idea of truncal, right? And so truncal ataxia is actually lesions that occur in the midline of the cerebellum. So this is really easy now. If you think about the cerebellum has a middle part and a lateral part, think that lesions in the midline have to do with your midline, right? Your middle part. And it turns out that the lesions in the more lateral aspect of the cerebellum have to do with the lateral aspect of your body, the limbs. So truncal ataxia is really an incoordinated movement of the trunk itself, and it really gives rise to an unsteadiness of walking. Whereas appendicular ataxia is a problem with the movement of the upper, like specifically the arms, right? You get this inability of the one arm to move properly. And so we're going to see actually how this applies. But if you think about, again, how we've done this sort of thing, right? So that lateral corticospinal pathway, right, was about your extremities, right? Lateral corticospinal was influencing the extremities. And the more lateral aspect, right, the more lateral aspect of the cerebellum is again about your extremities. And the more medial aspect of the cerebellum is about the more medial aspect of you. So it's a really cool thing. And then lesions in the middle of the cerebellum give rise to that truncal ataxia, unsteadiness of walking, and this more lateral lesions of the cerebellum give rise to the appendicular ataxia. So we're going to see that now in just a moment. The cerebellum, I have to tell you, is an incredibly complicated little structure, but if we think about it in a very simplistic way, if you look at it from this view here, this dorsal view, we actually can see the fact that by the hatched lines there's this midline part here, and there's an intermediate part to it, and then there's this huge lateral part over here. So we actually have three different parts. So there's this midline vermis, an intermediate, and a lateral part, and that's actually how they're referred to. The cerebellum is really tightly linked to the pons, both embryologically and functionally. And we have these large cerebellar peduncles, and there are three of them on each side, that connect the cerebellum to the pons. And in this view here, we can actually cut away these peduncles to reveal this large space in here underneath the cerebellum, and that space would be the fourth ventricle, right? The fourth ventricle that has those three apertures, one medial, two lateral, that open up the ventricular spaces to the subarachnoid space. Now, there are other parts to the cerebellum, but from your clinical perspective, I think what's really important is you're thinking about these truncal and appendicular ataxias. You really only need to worry about the vermis, and as we're going to see, it's more this part lateral to the vermis, not so much the lateral part, but this intermediate part here, which is critical. So here we have the vermis, we have the intermediate, and we have the lateral. So here's a representation again of the cerebellum. So we have the midline vermis, then left and right of that we have the two intermediate parts, the hemispheres, and then the lateral part or hemisphere. And if you look at it, it's kind of interesting. So if we go back to these terms, truncal and appendicular ataxia, and we think about what they're actually doing, then look at what's actually happening here. The vermis is controlling proximal limb and trunk coordination, right? The midline of you. How do you maintain your posture? And the intermediate part is all about distal limb coordination, moving your hands in space, your wrists, your elbows, right? And so which pathways are they helping? Now if you look at it, wow, it's actually the two we've already done. So when we think of distal limbs, that's lateral corticospinal, right? That precise movement of our fingers, our ability to wiggle the toes, right? Lateral corticospinal pathway. Remember, rubrospinal we tossed because not quite sure exactly what it does in human beings. And then we think about the midline of the body, the trunk, who's influencing that? Anterior corticospinal. And we knew there were some helper pathways like reticulo and vestibulo. Okay, well that's fine. But sure enough, there it is again. And so if we look at it now, there's this, you can see that the cerebellum is influencing specific parts of motor activity. And these specific parts of motor activity we've already done. So you can link now very tightly the vermis of the cerebellum, right, with the proximal truncal muscles, and think how it must be helping anterior corticospinal. The intermediate hemisphere of the cerebellum, which there are two of, left and right, is influencing distal coordination. And we know that the distal limbs are completely influenced by lateral corticospinal, and so that's what it's helping out. So here we actually have, and then if you just look at the cerebellum itself, and you think representing the human body on it, in the midline, the vermis, that's the midline of the body. And then on either side of it, we actually have the lateral portions. Now, what's kind of interesting is the fact that this lateral hemisphere, this lateral part, which looks like the biggest part of the cerebellum, is actually more about the planning. And it's pretty clear in humans and in lots of animal studies like cats that you can remove this bit of tissue and people are pretty okay. So it's kind of interesting. There's a lot of tissue in the cerebellum that actually can be lost without any really serious deficits. And so that's why you get this sort of more unclear definition of motor planning, right? planning, what's going on there. Whereas clearly the intermediate is regulating distal limb coordination and the vermis regulating truncal and proximal limb coordination. Great. Okay, so here is now going to be some of these slides that we're just going to pass over, and I'm going to mention the few things and not get bogged down in the details. All right, so look, the human nervous system has far too much excitation going on inside of it. And in fact, the predominant type of synapse, the predominant molecule being used in the brain is the inhibitory neurotransmitter GABA. We need to suppress all this excitation going on, so that when excitation does occur, when you want to do something, it's almost like you're releasing, right, the inhibition, and something positive can actually happen. And the cerebellum is very much like that. It's got this tremendous degree of inhibition going on inside of it. And that when you release the inhibition, that's when you actually allow for positive activity to actually happen. So the cerebellum actually is composed of a cortex, so just like the cerebral cortex, this is now the cerebellar cortex, and it has these deep nuclei, and the deep nuclei are named dentate, interposed, and vestigial. And we're going to just try to link those up as best we can. So there are lots of pathways that come into the cerebellum that regulate its activities. And the one that's just worth mentioning, because we've used this nucleus as a landmark for the medulla, and that is this inferior olivary nucleus. So we have these fibers referred to as climbing fibers that work their way into the cerebellum that arise from the contralateral inferior olivary nucleus, which we know is in the medulla. And these provide a very strong positive input to neurons in the cerebellum. We also have another input referred to as mossy fibers. Now, nowhere, I'm confident, once you've passed your step 1 exam, is anybody going to ask you about climbing and mossy fibers, right? The concern is, what might you get asked on this exam? Like one question about the cerebellum. And I'm always concerned the fact that they're going to show you something like this, which is basically a very typical view of the histological organization of the cerebellum. And let me tell you, I mean, people have spent lifetimes trying to work this stuff out. It's very complicated stuff. And it's incredible when you look at its intricacy. But, that's neuroscientists, right? This is not for you as clinicians worrying about why someone's got a truncal ataxia, right? So, what I want you to think of is when you look at this schematic is the fact that you recognize that when we're talking about inputs coming into the cerebellum, if you think about it this way, the inputs coming into the cerebellum are tremendously positive. Doesn't matter what specific type those are. So that means these climbing fibers, these mossy fibers are providing excitation within the cerebellum. But the outflow of cerebellar activity, which is what is on this nice schematic here, is inhibitory. It's shutting things down. And when you actually release this inhibition, this is actually when you allow for a positive outflow of information from these deep cerebellar nuclei. Now, what does that really mean? Well, the workhorse within the cerebellum is this one big neuron here called the Purkinje cells. Where else have you heard Purkinje's name being used? Right, Purkinje fibers in the heart. So Purkinje is definitely one of those guys who we definitely keep, his name associated with these cells because these were important things he found. These Purkinje neurons are receiving all of this excitatory input. And if you excite an inhibitory neuron, that means it's telling other neurons, don't do anything yet. And so these big Purkinje neurons are the ones that are projecting out to actually innervate their deep cerebellar nuclei. So what does this mean for the whole circuitry? So here's a huge chart with a lot of information on it, but we can put it down in like probably 2 phrases. Because I don't want you knowing all these tracks. I don't want you knowing all these different names. But there's probably two things we can say here. So the one is the fact that clearly we actually have the cerebellum being regulated by these two sets of nuclei. We've got climbing fibers coming in, and we've got these pontose cerebellar fibers and the mossy fibers coming in. All right, and that's all right. So that's providing excitation into the cerebellum. But if you want the cerebellum to influence motor activity, and this is very intuitive now, if you want the cerebellum to influence motor activity, what type of information should the cerebellum get? Right? Well, it should get proprioceptive information, right? Not pain and temperature, not vibration, proprioceptive information about what's happening with your skeletal muscle and what's happening with your joints. And sure enough, that's a lot of what it gets. It's getting a lot of proprioceptive information from the spinal cord. It gets information from the spinal cord that it has to work out. So if you want to influence ongoing motor activity, you better be receiving some proprioceptive information. So all this information on this chart here can be distilled down into two phrases. First one is the cerebellum receives a lot of excitatory inputs. That's from these climbing fibers and from these pontocerebellar mossy fibers. Phrase number one. Phrase number two, if you want to influence ongoing motor activity, you better be receiving proprioceptive information. And sure enough, that's exactly what they're receiving it from the arm, from the leg, right? So they're getting lots of proprioceptive information. Now, how do we put all this together to make it easy? So here we actually go back to now our a nice chart to actually talk about the different parts of the cerebellum and what they do. So we know that the vermis is involved with the control of the proximal trunk movements. We know the intermediate hemisphere is involved in the movement of the extremities. So we can actually piece together some of these nuclei, these deep nuclei, with these specific parts of the cerebellum. And then where are we sending this information? We're sending it to the thalamus. The only thalamic nucleus I've told you about so far are two, the ventral posterior lateral and ventral posterior medial. So now we can add on to that the ventral lateral. The ventral lateral nucleus is the one that receives the cerebellar information and then projects onto the cortex. So in this chart, the important things to recognize is that we have two parts of the cerebellum that control activity, vermis, intermediate. Sure, if you want to learn their names of deep nuclei of the influence, I don't mind. I'm not going to ask you because I could never remember them. But the important thing is that this outflow of information influences the thalamus. Right? The cerebellum does not directly connect with the cortex and influence those cortical neurons. Rather, that thalamus is coming in again as this sort of relay nucleus. Now it's relaying information from the cerebellum to the cerebral cortex, and now from a specific nucleus, that ventral lateral thalamic nucleus. All right. So how do we actually try to put all this together in a nifty pathway? Now, I'm going to show you this. I'm not expecting you to give it back to me in any way, shape, or form. But this schematic, we just walked through it. It really shows you about how information in the cerebellum on the right side influences right-sided motor activity. And it's this idea of the information, when I say information, right, we know that there are probably several neurons in the chain, the information crossing the midline once, and then the information crossing the midline again. So, here we actually have our cerebellum. So here's our cerebellum here. And we know that the Purkinje neurons in the cerebellum, right, are providing that strong inhibitory input to these deep cerebellar nuclei, and the one shown here is the interpost. It's that nucleus, not the Purkinje neurons, right? It's these deep cerebellar nuclei that then project, and they want to influence motor activity. How do they do it? These deep cerebellar nuclei, when their inhibition's been released, fire, And they actually innervate, they actually do influence neurons in that ventral lateral thalamic nucleus. Huh. It's these ventral thalamic nuclei that then project onto the cortex. What part of the cortex? Well, if you want to influence motor activity, better be the motor cortex, or at least the associated motor cortices, right? But we know that that motor cortex, now, when you actually modify that activity, right, that motor activity, specifically going to your distal limbs, those axons now project down. They're projecting through the brain to the internal capsule. They come into the brain stem. And we know at that cervicomedullary juncture, these axons cross the midline, right? And to influence neurons, spinal neurons in the spinal cord. So, if you could imagine that a lesion within the cerebellum, right where my hand is here, right? That intermediate part influencing distal limbs. The lesion is blocking activity within this deep cerebellar nuclei, the interpost. And if we look at it, then that means that there would be something wrong with our projection of the thalamus, the cortex. We cross the midline once, and then that information then crosses the midline yet again. And so that lesion on the right side of the schematic would result in a right-sided appendicular ataxia. So the lesion on the right, because that's where the activity is coming from, that's modifying the activity over here, right? If this activity is not modified appropriately, you end up having this ataxia, the inability to have these wonderfully smooth movements. And the same will apply if we actually influence more the midline structure of the cerebellum, which influences the vestigial nucleus, and then it's the same sort of thing, but now it's the anterior corticospinals rather than lateral corticospinal. So, the cerebellum, incredibly complicated with its pathways, incredibly complicated with its cytoarchitectural organization. But if you distill it down to some real basics, that's what you need to know from a clinical perspective. The fact that the cerebellum has these two parts, the vermis and the intermediate. Attached to these, or what you actually have as outflow of activity, are these deep cerebellar nuclei. And we know that these deep cerebellar nuclei project to the cortex via the thalamus, specifically the ventral lateral thalamic nucleus. And it's because we think about this distal coordinated limb movement that these deep cerebellar nuclei here projecting through the thalamus, influencing that part of the homunculus, right, for your distal limbs. It's these neurons, then their activity is being modified, and then they are activating neurons within the spinal cord. But which neurons in the spinal cord? The neurons on the same side of the cerebellum, because that information crosses the midline once and then crosses the midline a second time. So, what does all this mean then with regard to the clinical presentation of the individual? So I'm just going to come back to that in a moment. So for appendicular ataxia, when you think about it, we human beings can do a really simple task. So you're going to ask the patient to actually, you're going to hold up your finger, and you're going to ask the patient to go from nose to finger. Have you done this with Dr. Cooper already? Great. So now you've done the clinical aspect, now you get the anatomy, right? So how is it that we do this so fluidly? Cerebellum. We know it's the cerebellum because if you have an infarct in the cerebellum, all these wonderful blood vessels that provide vascular supply to the cerebellum, if you have a specific infarct of the cerebellum, that is, you've cut off the blood supply to that intermediate part of the cerebellum, people don't do this properly. And they don't do it properly on the side of the cerebellum that is lesioned. So that's why you have this ipsilateral presentation. You will be told that the patient has an infarct in the right intermediate hemisphere of the cerebellum. And when you go to check them for their appendicular ataxia on the left, oh yeah, that's nice. That's going back and forth very smoothly. And on the right, clearly, it's the cerebellum. why is it the cerebellum, right? If you know that the lesion's in the cerebellum, we know that there's no infarct in the thalamus, there's no infarct in the motor cortex, in the internal capsule, the spinal cord, right? So that lesion within the cerebellum clearly has an ongoing effect on the outflow of motor activity. So it's not simply that it's there to figure out how we do it. Once we've learned how to do it, then we don't need the cerebellum anymore. No, 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 no. It's on a moment-by-moment basis for everything we do. That the cerebellum is fine-tuning our motor activity. And that by having lesions within the cerebellum of people that you will meet with these cerebellar lesions, you will see this ipsilateral presentation of appendicular ataxia. Now, truncal ataxia, as Dr. Cooper would have told you, is where people have sort of a drunk-like gait. They put their feet very wide when they walk. They're very unsteady. And that's again because there's something wrong with their uprightness, right? Their truncal muscles are not working properly. And if you think about that cerebellum, right, there's a midline part and the part next to it. The midline is your midline, and the part next to it, that intermediate hemisphere, are your distal limbs. And if you distill it down to those basics, I promise you that that's exactly what you're going to need in the future. Because this is much more complicated than you'll ever have to know after you write your step one. Now, here's a little trick. Because again, when I came down the first time, someone showed me some of these practice questions. And this thing was on it. And I was like, that is so unfair, right? I don't get why they had this picture, not this exact one, but it's very stereotypical of all the histological pictures in the cerebellum. I was like, why do they have this? It's really unfair. But they were pointing to these really big neurons, and what do they do, right? And so, they shouldn't be asking you about these nitpicky little neurons all over the place, but really the big workhorse neuron, which are the Purkinje neurons. And if you just remember, Purkinje is that guy, the Purkinje fibers, right? And it's that these Purkinje neurons are not innervating the thalamus directly, they're not innervating the cortex directly, rather they're providing inputs directly onto these deep cerebellar nuclei, and their influence is negative. It's inhibitory. And if that's what you take from that one schematic, I think that's more than enough. We've got lots of inputs coming in, but the output is all inhibitory, and that's what's being shown here. This idea of inhibiting neurons, and then when you release that inhibition, you allow the neurons then to fire within that deep cerebellar nucleus. And again, please do not learn all this stuff on here, completely unnecessary. But if you distill it down to the basics of excitatory inputs and proprioceptive inputs, that's fine. So the other thing with cerebellar lesions, so I'm just going to mention this because it's on here now. The other thing with cerebellar lesions is that people will complain of being nauseated, they'll be vomiting, right? They feel very unwell, they're where they are in space, etc. And the cerebellum is very intimately connected with the vestibular apparatus, the vestibular nuclei. And so things going wrong with vestibular function into the cerebellum gives this sense of nausea, uneasiness, dizziness, etc. And so just that you recognize that the cerebellum and the vestibular information are tightly linked with each other, that's general enough. So just that you understand that when people actually have these cerebellar hemorrhages or cerebellar infarcts, it's always this vertigo, nausea, vomiting thing that goes along with it. And that's because of all these vestibular inputs to the cerebellum. So they're getting a lot of, and obviously you want vestibular inputs because of what? Being upright, knowing where you are in space, right? Just makes sense. Good. All right, so that's great. So you've done this with Dr. Cooper. You have a good idea about it. Now you have some idea about the anatomy, and you have this, hopefully, this really clear idea about why the lesions that present are ipsilateral, right, to the damaged tissue. Great. All right, well, that's the cerebellum. We got through that pretty well. Oh, for those who came in, so evidently I have a formative quiz posted on your file. which I've forgotten about. So I am going to put the answers together now, probably a break, and then you'll have them. So we'll post them. All right. So if it were only so easy that ongoing motor activity only needed the cerebellum, we wouldn't have this lecture, but it doesn't work that way. So humans, primates, cats, even rats need actually two sets of nuclei, structures helping out with motor activity: the cerebellum and the basal ganglia. Now, I've mentioned before that the basal ganglia is an unfortunate term because really when we think of the word ganglia, it's these collections of neurons peripherally, right? We have sensory ganglia and we have autonomic ganglia. Well, unfortunately, we also have this structure called the basal ganglia, which is actually in the central nervous system. Just a caveat about words. Now, if we look at the basal ganglia in our schematic, and this is like one of the first schematics I showed you, now we can really begin to fill in, right, all the different names we've done. So here we actually have the cerebral cortex, which you know is that major outflow of information for our lateral and medial motor systems. Lateral corticospinal, medial, the anterior corticospinal, plus some helpers like vestibulospinal. We also have brainstem influences going on. That the cerebellum modifies ongoing motor activity we've just done, in so much as the fact that it is projecting directly onto the thalamus, which then goes on to integrate cerebral cortical neurons. And the same is true for the basal ganglia. That is, the basal ganglia is relaying information to the thalamus to control ongoing motor activity. And we know, again, that these nuclei within the basal ganglia must be affecting motor activity because discrete lesions of these basal ganglia structures give rise to different types of motor problems. So these ideas about anatomy and function from a clinical perspective really came around, right, by clinicians looking at people who developed motor problems, and then when they died, asking, what's wrong in their brains. And then you carefully describe what's gone wrong with them through their life, and then you look at their brain and go, there's a lesion in the cerebellum versus now maybe a lesion in the brain, in the basal ganglia. Then it gives you some clear indication that these structures must be very important for influencing ongoing motor activity. So as much as the cerebellum, lesions of the cerebellum give rise to ataxia, this idea of being uncoordinated distal limbs, uncoordinated truncal muscles, proximal limbs. For the basal ganglia, we can define the disorders in two ways. Either it's a hyperkinetic disorder or hypokinetic disorder. And I think you get the idea of these two words. Hyperkinetic is there's too much going on, and hypokinetic is there's not enough going on from a motor point of view. Now, I know that I think in term one you've probably already done Huntington's disease from a genetic point of view. Yes, I think so. Yeah. See, I'm aware of things in your curriculum. All right. And Parkinson's disease you probably haven't done at all, or no. But Huntington's you did do from a genetic point of view. Excellent. Both of these we know are really unfortunate neurological disorders, but they are very different because in Huntington's disease there's too much activity going on. There's this jerking, flailing, twisting movements going on. Too much activity. In Parkinson's, if you look at a patient, they're sitting there, their face is kind of a flat affect, right? They have trouble getting up out of a chair and getting going. They have trouble getting their buttons done up, right? They have this inability to get going. So you're slowing things down, right? So we've got too much movement, too little movement. And it turns out too much movement is a good example is Huntington's disease, and too little movement of a hypokinetic disorder associated with basal ganglia is Parkinson's disease. Now, what we want to do is have a good general understanding of how the anatomy is influencing this, these two outcomes. How the anatomy of the basal ganglia and lesions therein could give rise to deficits seen in the cerebral cortex with regard to ongoing motor activity. What is actually happening here? So the basal ganglia are actually this now, when we actually, so I kind of glossed over all the specific names in the cerebellum. So in the cerebellum, I said the vermis, absolutely. Intermediate hemisphere, absolutely. Don't worry about the deep cerebellar nuclei. I completely agree with that. But in the basal ganglia, unfortunately, there are some names now that you really do have to commit to memory. So we have, first of all, the striatum that consists of two structures, the caudate and the putamen. There is another structure, the globus pallidus, a subthalamic nucleus, and then the all-important, certainly for Parkinsonism, the substantia nigra. So anatomically, these structures are deep to the cerebral hemispheres. And they are, in fact, part of, in fact, three of them, the striatum and the globus pallidus, are part of the telencephalon. So from an embryological point of view, these deep structures are developing with the telencephalon, that is the cerebral hemispheres. Just by its name, subthalamic nucleus, what part of the brain would that be? The diencephalon, right? Thalamus, hypothalamus, epithalamus, thalamus, subthalamus, right? Diencephalon. But the substantia nigra is found in the midbrain. The substantia nigra is a major structure within the midbrain. So, again, here's one of our osmium-stained sections of the human brain. And so now what I'd like everybody to do is just watch for a little bit. I just want to do some basic anatomy. So let's just go through some basic anatomy first. So, if I were to tell you that these two large spaces here are your lateral ventricles, right? One on the left, one on the right with a septum in between. It's not a midline structure, right? Two lateral ventricles. We know this is osmium stains. That means everything that's myelinated, right, is darkly stained. So we've got this massive amount of dark tissue going from one hemisphere over to the right. So that would probably be the corpus callosum. Excellent. Down here, we actually have what looks like a midline structure, but actually it's kind of thicker on left and thicker on right. That actually is the chiasm right here, your optic chiasm. Probably, depending on the section, giving rise to the optic nerves out here, or maybe just giving rise to the optic tract. I can't tell. But this is the chiasm right here. The hippocampus is somewhere right in here. Our hippocampus is nice and deep, and it's somewhere way down here. We know that's all about memory learning. So our basal, so if you look at this white tissue here, this little bit here, here, and here, well, that's your cerebral cortex. And all this dark stuff are all these myelinated axons, right? Between connecting neurons on the same side of the hemisphere, connecting neurons from left and right, right and left, or the axons that are projecting down, like corticospinal, corticobulbar, going somewhere else. And in amongst all this really dark tissue, which we know are the myelinated axons, we actually have our different parts of the basal ganglia. And so these include the caudate, and then we actually have the putamen and the globus pallidus. So we have these three structures all closely related to each other, and they're actually deep to the cerebral hemispheres. And we can see how these really are close to them, even though they're deep, and they develop embryologically along with them. So this is a lateral view here of how they're organized, and this is more of a slice that actually gives you this presentation. So we can see the two lateral ventricles, real spaces, and then on either side we can see the caudate, and then the other big bit of white is the putamen, and then more medially we actually have the globus pallidus. I've got that labeled on the next one. I believe. Yeah, right there. So this is now, remember this schematic that I've referred to a couple of times? It won't really make sense until we get to a certain spot. Well, here we are. So we can take now this horizontal view of the human brain. So the nose is up there, right? The back of the head is here. And it may be a little difficult to see, but here are our nuclei again. There's the caudate, there's the putamen, globus pallidus. And now, here they are here. So there's caudate, putamen, globus pallidus, like this schematic represents right here. This big thing, if you go back to the labeled one, is the thalamus. And there's our corticospinal pathway, arm, trunk, and leg, and cortical bulbar right there. Traveling along. So we now can add a few more things. So, before we take a break, just to mention, and you've done it before with Dr. Cooper, that the globus pallidus, the putamen and the caudate, the nuclei of the basal ganglia, are receiving a massive blood supply from branches off that middle cerebral artery. And these branches are referred to as the lenticulostriate arteries. So before we get to the superficial aspects of the middle cerebral artery, going superior over the frontal and parietal lobes, right? So superior coming out over here, and inferior coming out over temporal, deep to this, they're giving off these lenticulostriate arteries that are supplying the basal ganglia. So very important. So not off anterior, not off posterior. These are off the middle cerebral artery. And that middle cerebral artery is that biggest branch off the internal carotid. So you can clearly see it there. All right, so let's take a break, 12-minute break, because, you know, I have to keep talking as well. Okay, so back to basal ganglia, and we have our different parts, the caudate, the putamen, and the globus pallidus, all of which are receiving these lenticulostriate arteries from the middle cerebral artery. And this is before this major artery gives rise to its superficial branches, which are supplying the frontal, parietal, and temporal lobes. So here's that schematic again. So now we can actually start to layer on a few things. We can actually see the nuclei we're going to do today, this caudate, putamen, globus pallidus. There is our cortico-bulbar pathway, corticospinal pathway. We're going to do optic now in just a moment, auditory not at all. Here's the big thalamic nucleus there, and here's our internal capsule, bringing these axons of from the cortex down to deeper structures. And basically there's where this schematic fits in a real section of the human brain. So I try to make it as close as I possibly could. So these three structures are really part of the telencephalon, and yet our other two, the subthalamic nucleus, diencephalon, but it's really critical for you to recognize that the substantia nigra is part of the midbrain. Now this is a really odd section here because we've got the thalamus and the pons all in the same section. So it's kind of an oblique section through the human brain. Hopefully one you would never see, and certainly one you would not get on a scan. So this is very oblique, but it has actually all of these nuclei in it. But again, pinpointing these nuclei on a section is not my expectation. So when we actually think about what the basal ganglia is doing, it's again, like how would it be influencing motor activity? So when we think about it, virtually all the inputs to the basal ganglia are arriving via the caudate and putamen. The inputs are going to structures like the globus pallidus and the substantia nigra, and we're going to see how there's this complex excitatory inhibitory connections going on. And again, it's this, going on with generalized motor activity. But I can tell you that the basal ganglia does a lot of other things as well that we're not going to get into today, but certainly may come up in a clinical presentation of a patient where there may in fact be other deficits. And certainly with Parkinson's disease, as it progresses, people do develop cognitive impairments. So in the very early stages of Parkinson's disease, it's purely motoric. And then with time, as they continue to age and the disease continues to worsen, cognitive deficits do actually creep in. So you can actually get some idea here about how the basal ganglia has even a few other functions. Okay, so here we are again with a really cool pathway, and so the idea here is what? So we have on this schematic a bunch of pluses and a bunch of minuses. So again, pluses are meant to designate an excitatory input, and minuses would be an inhibitory input. And so if you look, the one thing you can say about the basal ganglia is that it is definitely receiving a lot of excitatory inputs from the cortex. So the cortex is actually sending lots of excitatory inputs down to it to regulate basal ganglia function. But as much as that's interesting, there's one center here that's providing a dual input to the caudate and the putamen, and that is actually the the substantia nigra compacta. So what is the substantia nigra compacta? So this is that nucleus in the midbrain, and here we find these neurons that are dopaminergic. They are using the neurotransmitter dopamine. So these dopaminergic neurons send axons to the globus pallidus, to the striatum, and they're exerting both excitatory and inhibitory effects. How can one neurotransmitter be both excitatory and inhibitory? What's the one word that has to be put there? Well, how about receptor? The receptors that dopamine bind to, some receptors must exert excitation, and there must be other receptors that are very different that exert inhibition. That's the only way one neurotransmitter can have two completely different effects. And it turns out that within the striatum, there are dopamine receptors that convey inhibition, and there are dopamine receptors that convey excitation. And so this is how you're able to have this duality of function. We know that it's the substantia nigra compacta, these dopaminergic neurons, that are lost in Parkinson's disease. What kills them? We have no idea. That they die? Absolutely. And just from an interesting scientific point of view, because I like to sprinkle some of this into your clinical stuff, but from a scientific point of view, if you think of that, the substantia nigra compacta sends axons to the striatum, and that it's this loss of dopamine by these neurons in the striatum that actually gives rise to Parkinsonism. So I don't know if someone's told you this before, right? It's very, very cool. So what proportion, just proportion, do you think you have to lose of these neurons by the time someone actually presents to you with even the earliest Parkinsonian symptoms? Have you had this before? Someone has mentioned this? It's an incredible number. It's about a 90% loss. A 90% loss of these neurons before people will begin to complain about tremors, like an inability to initiate movement, problems with fine motor activity, like doing up buttons. What do you think that is going on in the brain as you're losing 10% of the neurons, 50% of the neurons, 80% of the neurons? Well, the surviving neurons sprout new axons within the striatum, and they try to make more and more and more dopamine to supply the system. But you just get to a point where 10% seems to be the magic number that the system can't do anything more with. And by having almost a 90%, you think about by the time they come to you, I mean, it's all so late. I mean, 90% of the neurons are probably, somewhere in the vicinity of 90% of the neurons are lost. And so that's a tremendous deficit, if you think about it. But in the meantime, while they're non-symptomatic, these individuals have neurons within their brain that are trying to compensate for this loss of dopamine within the striatum, because we know it's these neurons here, it's this loss that gives rise to Parkinsonism. So clearly, as we're going from 10, 20, 30, 40% loss, these remaining surviving neurons are trying to compensate somehow by probably increasing their dopamine production, increasing their axonal arborization within the striatum. Very, very cool. But unfortunate from a clinical point of view, because by the time you see the patient, they've lost them. And when you've lost neurons, that's it, right? There are no new neurons coming back. So there is no population of stem cells within the substantia nigra that will replenish these lost neurons. When they're gone, they're gone. That's what makes these diseases so permanent. We think about what's then flowing out of the basal ganglia, and again, look at all the negatives everywhere. It's again this idea of inhibiting things, right? Sending out inhibitory signals to other places. And one of them being the thalamus. And we know that the thalamus is that important relay nucleus for the basal ganglia, and an important relay nucleus, as we just saw, for the cerebellum. So it's not surprising there are a bunch of thalamic nuclei that are relaying basal ganglia information onto the cortex. Okay. So then we end up with this kind of schematic. Now, there's a lot of information on here. And, I mean, if this was a course that we had 3 weeks in, this would be probably a full day's worth of lecture, all right, just to tell you all about this. That's not happening. So what I want to do is to give you the absolute bare essentials of what's on here. So we have a system, this collectively, this basal ganglia, that we want to do what? We want to influence motor activity, cortical motor areas. Somehow we want to influence it. Just like the cerebellum, the basal ganglia is not sending axons to the spinal cord or the brainstem. Just like the cerebellum, the basal ganglia does not project directly to the cortex. Rather, it funnels the information through the thalamus. What kind of information, ultimately, do we want to go in there? Well, really what we're trying to do again, if you look at it, this system, there's a whole bunch of negatives everywhere. And it's the idea, again, of suppressing too much excitation. And if you think that something like a hyperkinetic disorder, right, where you have no control of the excitation, can be kind of like a seizure, right? Seizures are kind of the same thing. You know, seizures occur because that dampening of the excitation is gone. And if you think about the brain as being this incredibly excitable tissue, you want to keep it suppressed. That's what's really going on in the brain. It's this constant suppression of activity. And when you release it is when you want something meaningful, purposeful to happen. And having a hyperkinetic disorder is neither purposeful nor meaningful, right? And so clearly there's not enough inhibition going on, right, to prevent this flailing movements all over the place. So if you look at the basal ganglia, so we have our striatum and our globus pallidus, and there's an external and an internal part. And if we look at it and we say, well, it seems to be all about dampening down activity of the thalamus, which then relays that excitatory information onto the cortex. So if we remove that inhibition, there would be too much excitation, too much of a motor activity that is not wanted. So Huntington's, curiously enough, is all about the loss of these inhibitory neurons. Oh, I mean, if you lose inhibitory neurons, then the amount of inhibition you had to suppress the outflow of information must be gone. And in fact, Huntington's disease selectively targets these neurons within the basal ganglia, like neurons within the striatum and the globus pallidus. So you get a hyperkinetic disorder. There's too much going on. Now, GABA is that inhibitory neurotransmitter. And you can see here there's lots of GABA throughout here, and ultimately we're trying to keep the thalamus only working enough, that thalamic nuclei part, that are sending excitatory innervation to the cortex, specifically those motor areas of the cortex. So, Huntington's with too much activity, if you think about it, it's like the inhibition's gone. You've got too much excitation. And now things are not working out properly. So, and then when you look at this entire pathway and you ask yourself, well, who's doing anything? In Huntington's disease, it's the loss of these striatal and globus pallidus neurons. So if we lose inhibitory neurons, then guess what? There's not enough inhibition going on and you have too much excitation. In the case of Parkinson's disease, we actually have a loss of this dopamine coming in. Now, dopamine, as I just mentioned, can either have an excitatory or an inhibitory influence. And we see this on the box by our substantia nigra compacta and DA for dopamine having either an inhibitory influence or an excitatory influence within the basal ganglia. Here, there seems to be an imbalance then, or a loss of these inputs of dopamine, which are then basically slowing the entire system down. And it's almost like you've got too much inhibition occurring that things just don't get going. So the loss of dopamine is affecting these striatal neurons, and these striatal neurons are again like influencing thalamus, and thalamus influencing motor. And this is an ongoing influence, right, of motor activity. So if you slowly lose dopamine within this system, then you basically get this system sort of being far too much inhibitory, right? There's too much inhibition going on that you're really not getting enough happening. And that actually is negative as well. And almost to the point then, when you've depleted your dopamine stores almost completely, and clearly dopamine is critical, because we actually then have the manifestation of Parkinsonism. And you're probably aware, or you will be aware soon enough, that the great thing about Parkinsonism is the fact that you can supplement dopamine, or the precursor of dopamine, to humans, which actually are able to be utilized within the brain and actually restore some degree of motor efficiency and provide individuals with some degree of relief. So, in the case of Huntington's disease, it's the specific loss of striatal neurons. In the case of Parkinson's, it's the specific loss of substantia nigra compacta neurons. In Huntington's, it's the loss of these inhibitory GABAergic neurons. In the case of Parkinson's, it's the loss of these dopaminergic neurons, which can cause both excitation and inhibition of neurons within the pathway. So why do we actually have two? Well, if you look on basically the schematic, and I just want to introduce you to these terms, not that I'm going to expect it from you. But if you look at the pathway, there's something here called direct and indirect. And it's how it influences and where actually you get the inclusion of the subthalamic nucleus. And if you just look at it, the subthalamic nucleus is involved in this indirect pathway where things are sort of meandering around, ultimately to influence thalamus. But the bottom line of it is the fact that this dopamine that comes into the striatum is influencing these neurons and influencing their effects ultimately on the thalamus. So a big breakthrough in Parkinsonism has been the development of L-DOPA. So L-DOPA is the precursor to dopamine, and human beings can take this, and you actually have to make sure the fact that it gets metabolized preferentially in the brain. So there's actually an inhibitor enzymatic activity peripherally in the pill as well. So the fact that you actually get a preferential utilization or synthesis of dopamine centrally. Why? Does anybody know why you have to give the precursor L-Dopa rather than dopamine to Parkinsonian patients? Great. Doesn't cross the blood-brain barrier. Absolutely. So that actually is one of the curious aspects of dopamine, but the precursor does. And so you can get the precursor in there, and the synthetic enzyme that takes L-Dopa to dopamine, there's plenty of it everywhere in the brain, and hopefully you get that dopamine being supplemented within the basal ganglia. There's a curious side effect actually to L-Dopa treatment in Parkinsonian patients. Does anybody know what that curious side effect might be? Well, it turns out that there's a significant proportion of people on L-Dopa who develop compulsive gambling. Yeah. And so they have to be monitored very closely because you almost get like this ability now to get up and go again, right? Get up and walk and do things again. And it seems like you're walking to the casinos, right? So it's a really serious problem for families, you can imagine, right? Because here was this person who probably never bought a lottery ticket before and then developed Parkinsonism, which is heartbreaking. And then now they're better, but now they've got this urge to gamble the family fortune away. So it's a really big problem. So when you all joking aside though, when you meet a Parkinsonian patient, when you talk to the family, these are things that, you'll be asking about. Has their behavior changed? Has their interests changed? Oh yes, so they really, now, we really want to, go to the casino on weekends. Oh, is that okay? Well, no, not really. And then, you find things out. So there are two big breakthroughs here, right? So for Parkinsonism, the big breakthrough is L-Dopa. And for Huntington's disease, the big breakthrough is the genetic marker. I mean, this is a genetic disease. And whether or not people themselves want to be phenotyped, right? Genotyped, rather, to actually determine whether or not they want to have children, that's for counselors and genetic counselors, and for you as a physician to consult with your patient. Nonetheless, though, two big breakthroughs have occurred, right, with these disease states. But there's one fundamental issue that they share that I hope that you can appreciate. And that is when you lose these GABAergic striatal neurons, there are no new ones coming back. And then when you lose these dopaminergic substantia nigra compacta neurons, there are no new ones coming back, right? So you have ways of testing people to see if they carry the gene. You have a pharmacological approach to managing their hypokinetic disorder like Parkinsonism. But as long as when you look at these schematics and you think to yourself that these boxes represent real populations of neurons, and that when you lose them, you're not just losing the neurotransmitter, right? You're losing the ability of the nervous system to generate new ones, because that does not happen within these two pathways. So there's a lot of information on here, lots of different neurochemicals. I don't expect you to know anything about enkephalin or substance P. Glue is for glutamate, which we know is excitatory throughout the central nervous system. So we've got glutamate, obviously, if we want to excite or influence positively motor cortical areas, it makes sense that glutamine is being released from the thalamus. And there are a couple of other thalamic nuclei. VA, ventral anterior, but look at the other one, VL. That's where cerebellum went through. So it's kind of now making a little bit more sense, right? That these thalamic nuclei that are influencing motor activity may be receiving inputs from not just the basal ganglia, but even from the cerebellum. And so if you just intuitively think about these two presentations of lesions of the basal ganglia, the two big ones, Huntington's disease and Parkinson's disease. Too much activity, too little activity. You don't want the brain to give off too much activity, so you have to dampen it, you have to suppress it, you have to inhibit it. So too much activity must mean something's wrong with the inhibition. we don't have enough inhibition. And if you think about the loss of these striatal neurons, that's exactly what's happening. In the case of dopamine, it seems that dopamine, be it having both excitatory and inhibitory effects, is clearly causing an imbalance within the basal ganglia of neurotransmitters and function. And now, rather than having too much activity, there's not enough, right? These neurons just are not working properly at all, right? And they're just slowing the entire system down, if you want to think of it that way. And so that's why you have these two very different presentations, a hypokinetic disorder and a hyperkinetic disorder. And you actually have this idea of this very complicated system with lots of inhibition going on there. So do you have too much inhibition or too little inhibition? And it ties in nicely with those two diseases. So this is a human midbrain. So there, very nicely shown that we have a bit of asymmetry developing this person when they died. But I hope that you can see the substantia nigra here very clearly on the one side, and they have a bit of asymmetry going on the other side. But you can clearly see there's the loss of these dopaminergic neurons. So it's actually not dopamine you're looking at. These neurons are pigmented. And that's actually how it got its name, because when early anatomists would cut open a human brain and they looked in this area, they noticed that it was dark compared to the rest of the tissue. So the dark substance, the substantia nigra, and it's not the dopamine you're looking at; it's a pigment within these neurons. And the other thing you actually get with these neurons is actually the presence of these Lewy bodies. So these cytoplasmic inclusions, these very pink, distinctive structures within these degenerating neurons called Lewy bodies. And this is a characteristic feature that pathologists would use in addition to the loss of the dopaminergic neurons themselves to actually look at the status of the few that are in fact surviving, and they develop this pathological inclusion referred to as Lewy bodies. And there's some very interesting chemistry associated with Lewy bodies, none of which you would need to know for general practice. Okay? So, we did a cerebellum and basal ganglia, all about influencing motor activity. If you think about ataxias, a hyperkinetic disorder, hypokinetic disorder, you can really begin to put on now about how these systems are actually working. All right? And the one thing about, I should mention with regard to these ataxias versus the hyper and hypokinetic disorders is the fact that there's this wonderful ipsilateral feature with ataxias, right? Especially appendicular ataxia. But these basal ganglia disorders tend to occur bilaterally. So there's no left or right predominance, right? The flailing limbs are on both sides, right? You may have a little bit more on one than the other, but both limbs are affected. And the same with Parkinsonism. The entire face is flat, right? Unexpressive. You have problems with both hands in doing fine motor activity. Both sides of the body trying to get up and out of the chair. Okay? So these basal ganglia disorders are not really, they don't have an ipsilateral, a lateral component to them. Now, I want to just touch on a bit about a vision, and then we are on track, which is pretty good. And the reason why I just want to touch a few things, because some of the things here are directly relevant to the basic anatomy that I'm supposed to be giving you. And the reason why I don't get into too much more detail is because you'll have an ophthalmology block at some point in time later on, where the ophthalmologist will come in and describe to you much greater detail about vision and vision processing and the different disease states that occur. So some of this is actually going to be a little iteration, because I want to make sure that there are some core concepts here we have. And I think there are a couple of new ideas, and that's about it. The one is the fact that these retinal ganglion neurons really are part of the central nervous system, right? That their axons are myelinated by oligodendrocytes. And you're going to say, well, he said that now a couple of times. But I really think this is an important concept for you to know, that the axons from these retinal ganglion neurons that are found in the second cranial nerve, the optic nerve, are from the central nervous system, which means in that nerve you find oligodendrocytes myelinating these axons. Did you do any histology of the retina? You did histology? Vaguely? No? Well, the eye is kind of interesting, right? So actually to affect your rods and cones, we're actually talking about the light passing by these neurons and actually influencing the photoreceptive cells very deep. And then their signal transduction actually moves back out superficially. Kind of cool. So think about it. The light's actually coming in, it's affecting the cones and the rod, the photoreceptive cells, and then the transduction of information actually then goes from deep back out to superficial. But it's the cells that are relaying this visual information are the retinal ganglion neurons, and it's their axons you find within the second cranial nerve, the optic nerve. Now, the vast majority of these axons are really required for vision, right? We need to know what's going on in our environment. So the lion's share of these axons are all heading toward a structure called the lateral geniculate nucleus. Now, the lateral geniculate nucleus is a thalamic nucleus. So that's why this second cranial nerve is not associated with the brain stem. It's associated with the thalamus. It says lateral geniculate nucleus, and there's one on each side. And we know about this whole idea of now 50% of the axons are from one eye and 50% of the axons are from the other eye, because this is now the optic tract, which is heading toward the lateral geniculate nucleus. A very small number of axons, though, branch off and actually head toward a completely different structure in the tectum of the brainstem, specifically the midbrain, and these are actually found within the structure called the superior colliculus. Now, the superior colliculus actually got its name because these two colliculi look like hills. And so there are two superior colliculi, and just below them, two inferior colliculi. Now, I'm not going to do in any way auditory, because that will be left for more of a clinical application. But it's kind of cool that we have a lateral geniculate nucleus and a superior colliculus, and these both have to do with vision. Vision. If there's a lateral, there's got to be a medial, right? There's a medial geniculate nucleus. And if there's a superior, there's got to be an inferior colliculus. And these structures are all about auditory. They're all about hearing. So it's kind of cool. We think about vision and hearing, and we've got these two sets of structures, the lateral and medial geniculate nuclei and the superior and inferior colliculi, and we can actually divide them up between lateral and superior for vision, medial and inferior for auditory. Just so you know why they're there, in fact that they're labeled. And in fact, I think inferior is there, and another schematic, medial, was actually put there. So the lateral geniculate nucleus is definitely part of the thalamus, so that's important for us to know. And so vision then comes into what? So when you think about vision being picked up by these retinal ganglion neurons, right? And then they send their axons through the optic nerve. Some cross, some don't cross at the chiasm. Then they extend back into the optic tract, and they innervate neurons in the lateral geniculate. That means the second neuron in our chain are the neurons in the lateral geniculate. So the first neurons are the retinal ganglion neurons. The second neurons are the lateral geniculate neurons. 1, 2. Where do these neurons project? Well, these neurons project directly onto that primary visual cortex. And they have these big radiating pathways that head toward it. So again, there's this huge amount of information coming from the eye, funneling into lateral geniculate, and then lateral geniculate sending that information back and onto the primary visual cortex. And the primary visual cortex is found in the occipital lobe. The occipital lobe. Now there's a big fissure that actually separates the primary visual cortex, and that's actually called the calcarine fissure. And we're going to see how we actually have two parts of the primary visual cortex based on which side of this calcarine fissure they're actually found on. So here's now our visual pathway. We actually have our retinal ganglion neurons in the retina. We have all of our ipsilateral axons passing in the optic nerve. It's the 100% of the nasal axons that are crossing the midline, and 100% of the temporals that are staying ipsilateral. So that now when you look at an optic tract, we actually have vision coming from both eyes. So we have visual information coming from both eyes that then projects back onto the lateral geniculate nucleus. The neurons within here have these two major sets of loops or radiations. So we've got this Myers loop and we've got these optic radiations. And these are really just nothing more than axons projecting back onto the visual cortex. And then on the visual cortex, we have this segregation now between the upper part and lower part of the eye, and already we've actually got left and right going on. So how do we have left and right going on? So it's probably best to just do this by yourself and actually just trace out the lines. But if we just watch all for a second, I can just show you this. So here we actually have the temporal retina receiving nasal light on the right eye. So these retinal ganglion axons come in the optic nerve, in the chiasm, they don't cross, and they continue in the optic tract. Where are they getting visual information from? If you think about it, this is the right eye, right? Temporally, it's getting vision, right, coming from the left side. Which axons are joining it? Well, it turns out the axons that are joining it are the nasal axons of the other eye, because their axons come in, head to the chiasm, and cross. So if we look now at the direction of the lines for vision for the two eyes within the optic tract, they're both heading toward the left. And you can do exactly the same thing, both heading toward the right. So this is actually how we actually have the binocular vision. It's this idea of sharing this information on both sides of the brain from both eyes. And so on the right, we're getting the left, and from the left, we're getting the right. Pretty cool. We've already done trauma, so I'm not going to get into this. We've already done this one, so you can read this for yourself, about a lesion of the optic nerve. We've already done this one as well, a compression at the chiasm, probably by a pituitary adenoma or a meningioma, compressing on those axons, not severing them, but distorting them to the point that actually they don't send the signals, and you end up with this bitemporal hemianopia. But what gets really cool then is the fact that what about now if you damage the optic tract or the optic radiations? So if we look at these two lesions now, right, we're severing all the axons here or all the axons here. So basically, these two pathways at these points are carrying the same information. It's all and all. And if you think about what they're actually carrying information from, it's from the opposite visual field, hence this contralateral. And it's the contralateral side of the body. Okay, so this is on the one side, so it's contralateral. So if this is right, it's happening on the left half of both the right and the left eye. And it's the half. So we get this contralateral, it's happening in both, hemianopia. So what's curious is the fact that now we can have lesions. What kind of lesions might you expect? Like infarcts again, right? Strokes, definitely things like that happening. So very unlikely there would be trauma so deep back here, right? But definitely strokes occurring here, absolutely. That are cutting off the blood supply and ending up with this presentation. And so this is really important now for asking ourselves, what axons do we find within the optic tract? and what axons collectively are passing back toward the visual, primary visual cortex. But now, the eye, the human eye, you know, needs not just merely left and right? It needs up and down. And now you actually get into this idea of quadrants. And so how do you get quadrants? Well, the neurons located in specific parts of the retina that are picking up that visual information, they're segregated. And that's why we have these things called the Myers loop versus the optic radiations. And that's why the Myers loop heads towards the lower bank in the calcarine sulcus, and these optic radiations head in the upper. But you know the great thing about it all? It's always the opposite, right? So if these axons here are heading toward the lower part of the visual field, right, the primary visual cortex, it's the upper visual field that they're taking it from. And guess what? It's vice versa for the axons that converge on the upper bank of the calcarine fissure in the primary visual cortex. It's these axons that are carrying the information from the lower quadrant. Everything's always opposite, right? It's always the other way around. And so it's actually very cool. So again, because we're on the right, we're getting the left visual field, and now we can divide it into quadrants. So this is meant to be an introduction, right? So you actually have this general idea, so when you do ophthalmology, that you can say, well, it kind of rings a bell from what Dr. Kawaji talked about, and you can always come back and look at these images and sort of give yourself a nice refresher. But the bottom line of it is this: the eye needs this idea of quadrants. How do we determine ipsilateral, contralateral, left versus right visual field, upper quadrant, lower quadrants? And it's all just about the segregation of this information by these axons. It's where they're projecting, right? So if you think about it, all this information seems to be funneling into lateral genicular nucleus with no apparent organization. That could not be further from the truth. It's highly organized. Because these lateral genicular nuclei neurons, when they're sending their axons out developmentally, they're making very precise decisions as to whether they innervate neurons in the upper bank of the visual cortex or the lower bank of the visual cortex, left and right. So, it's a tremendously complicated process, none of which you need to worry about. All you need to worry about is, what do you end up with? What is the end result of this wonderful embryology, right? And the end result is this idea that the two eyes are working in sync, and that the information that comes back to the visual cortex is highly segregated, not simply with regard to the right or the left eye, or the right or left halves of the visual field. It's even with regard to quadrants within that visual field. So, as much as we certainly can have infarcts occurring along our pathway for the tracts and for our radiations of Meyer loop, we have to recognize that that occipital lobe is receiving blood predominantly from what? The posterior cerebral artery. And if you think that the visual cortex is in here, situated on either side of this calcarine fissure, that's receiving blood solely from posterior cerebral, then that artery is a major one supplying vision. And that if that artery goes, you're going to have problems with vision. The neurons that are receiving all this visual information are not going to work properly, and then the patient will present with visual problems. But you certainly also can appreciate that anywhere along this pathway, you can have problems. The disease state within the eye itself, damage to the optic nerve, compression of the chiasm, infarct on the tract, some infarcts in these loops of the nuclei itself, and most importantly, thinking that the posterior cerebral artery supplies the primary visual cortex back there. So there are our three major primary cortices: motor, somatosensory motor, with our homunculus superimposed on it. We have our primary auditory cortex here on the superior portion of the temporal lobe, and then back here our primary visual cortex in the occipital lobe on either side of that calcarine fissure. And that we have to appreciate that when it comes to our blood supplies, we're thinking about the middle cerebral being that all-important one for what? Face and hand motor, face and hand sensory, Broca's area for the generation of speech, Wernicke's area for the comprehension of speech, right? And then posterior cerebral for vision. Major arteries. Only a few structures. It's not so bad. Okay, last but not least, why do we need to share some of this visual information with that pretectal nuclei found in the superior colliculus? What could possibly be the purpose of this? Well, guess what? We're coming full circle to our whole thing about pupillary constriction, pupillary dilation. Why are you shining light in people's eyes, all the time? So it's important you're shining light in people's eyes because you're testing the efficiency of not just the transmission of vision into the central nervous system, but the appropriate response to that cue. What is the appropriate response? You take your little light, you shine it into somebody's eye, and on the side that you shine the light into, the pupil constricts. And we think about constriction, that's what? Ocular motor. There should be a compensatory constriction on the other side where you don't shine the light. Because it makes sense, right? When we go from a dark room to a bright room, we don't just constrict one eye, we constrict the pupils of both eyes. They do it together. Makes sense. That visual information comes in, and if it happens simultaneously, it needs to be shared. How do we share this information about light? Well, it's all right here. Vision has to come in via the optic nerve. And we know that a few of these axons do not go to the lateral geniculate, but rather end up innervating these pretectal neurons within the superior colliculus of the midbrain. We know it's in the midbrain because that's where you find the superior colliculus. The superior colliculi and the inferior colliculi are these two bumps on the tectum of the midbrain. But look what's happening. These axons from the right eye are providing innervation to both the right and the left tectal nuclei simultaneously. These neurons project onto who? Anybody? They project directly onto the Edinger-Westphal nucleus. Why Edinger-Westphal? Because these are the preganglionic parasympathetic neurons in the midbrain that are responsible for pupillary constriction. It's not ocular motor. There's a distinct nucleus, Edinger-Westphal, situated immediately adjacent to ocular motor. And we know it's immediately adjacent to ocular motor because these preganglionic parasympathetic axons use ocular motor to get from the midbrain to the orbit. And it's within the orbit they jump off to find that ciliary ganglion, in which we find those postganglionic parasympathetic neurons responsible then for that pupillary constriction of both eyes. So, this is important that you understand why you're doing this to people, right? And it's important that you understand the mechanism behind it. Vision comes in, you get that. Optic nerve, chiasm, tract, no lateral geniculate nucleus. Rather, these axons bypass lateral geniculate to bilaterally innervate these pretectal neurons in the superior colliculus. Bilaterally, these two neurons project onto both the left and the right Edinger-Westphal neurons. So everybody's being activated simultaneously. These activated Edinger-Westphal neurons fire, and they send their signals through their nerves, which is traveling in ocular motor, that jump off to innervate the neurons in the ciliary ganglion, which cause the pupillary constriction. So have you done this to each other yet? Have you shone light into each other's eyes or into a patient's eyes to look at pupillary constriction? You haven't done it yet in clinical skills? All right. Well, when you do it, just remark to yourself how fast it happens. All right? I mean, it happens incredibly fast. And if you think about it, we've got 1, 2, 3, 4 neurons that are being activated to ultimately constrict these pupillary constrictors, right? It's incredible. The interesting and important thing is that it happens simultaneously in both eyes. And when you see that not happening, you know there's something wrong. And chances are what's wrong is the fact that the information leaving the brainstem through the ocular motor, something is happening there in the absence of noticeable trauma with the eye. All right, so let's take a break here. We only have only a few more things to do. See, most of this is just repeat, but anyway. And then we'll let's take a break and let's do the cases then after that. Great. Okay, one small thing. I kind of misspoke and just want to clarify it. So the visual information that's coming into pretectal, it just goes to the one neuron on the side. I said bilateral. I misspoke. So the visual information comes in, goes to pretectal on the same side. The pretectal neurons project bilaterally to both ipsi and contralateral sides. That's the sharing of the information. So I misspoke about that. So visual comes in, goes to pretectal on the same side. It's these pretectal neurons that project bilaterally, and that they influence the Edinger-Westphal nuclei simultaneously, which then both fire and to get this bilateral constriction of the pupil. Just want to mention to you, someone even knew of Horner syndrome the other day, so clearly this is something that's been talked to you about. And I just want to mention the fact that, again, when we think about the eye and we're thinking about constriction, well, we can't forget there's also dilation as well. And that's controlled by those postganglionic sympathetics found in the superior cervical ganglia, the bifurcation of carotids. I've gone over this already, but I've sort of laid out for you here Horner syndrome, where it's basically the syndrome describing the loss of sympathetic innervation to the head. It could be the fault of some pathology of these sympathetic ganglion neurons. It could be some pathology of the outflow of information from the spinal cord, from the preganglionics, or, as we've said before, it could be a loss of these descending hypothalamic projections in that lateral medullary syndrome, right? But what you end up with is meiosis, which is a constricted pupil, which is the unopposed action of the sympathetics, or the unopposed action of the parasympathetics through the loss of sympathetics. We actually have our loss of the innervation of the tarsal muscles, the smooth muscles of the upper eyelid, causing ptosis. And then we actually have anhidrosis, so there'd be an absence of sweating of the face as well. But that one you would actually have to test for, whereas the other two would be very obvious to you just by visual examination. So, just to let you know about Horner syndrome. So I provide you just with this schematic to say, just to remind you again that these postganglionic sympathetic axons travel along internal carotid, then they come along the first branch off that, which is the ophthalmic, to reach the eye. So don't think that these really important sympathetic fibers are traveling superficially along facial, right, to ultimately get to the eye. They're far too important to be vulnerable on the superficial branches of the external carotid. Rather, they travel along the internal carotid, highly protected, travel along ophthalmic, and then jump off ophthalmic to innervate the tarsal muscles, the pupillary constrictors, right? But the sweat glands on the face, which would also be affected, would be more those peripheral blood vessels. You already know about the anatomy of the eye. I just put it on there again as some nice schematics. I've already provided you with that chart. So, what I'd like to do now is just some quick anatomy here. So I think we are going to be good on time. So if we do some quick anatomy here, some of which Dr. Cooper has done, some of which I have done, and this is a really important view of the brainstem and associated blood vessels, cranial nerves, etc. And so what is actually going on here? So we just go from the top to the bottom, make sure we know everybody there. There's the optic nerves leading into the optic chiasm. And right behind that is that pituitary, giving rise to possibly pituitary adenomas to compress that optic chiasm. There's the internal carotid.
It's already given off its ophthalmic branch, but the branch we can see here is this posterior communicating. Now what makes posterior communicating kind of cool is the fact that it travels along with this large nerve here, ocular motor. There's our tentorium cerebelli, this very rigid edge, right, that allows for this opening here, this tentorial notch, for the brainstem to pass through. And we know this is at the level of the midbrain for several reasons now. Several good reasons we know this is the midbrain. One, the substantia nigra is only at the level of the midbrain. Two, the red nuclei we've used to identify the midbrain, not so sure about its function. But the substantia nigra we now know is providing that dopamine to the basal ganglia. We know that this is also the midbrain by the fact that we have the cerebral aqueduct, around which we find that periaqueductal gray, which are relay nuclei for pain. On the just now posterior to all this is the superior colliculus, in which we find those pretectal neurons that are innervating those Edinger-Westphal neurons. There's ocular motor, as close to the midline as we can possibly get. And that's our major cranial nerve associated with this level of the brain stem, the midbrain. Within the midbrain, we know there's this diffuse reticular formation. And if we're in the midbrain, we must be in the rostral end of it. So is this more for autonomic reflexes or for conscious alertness? Rostral is consciousness. Caudal is for autonomic reflexes. So this is about alertness up here. Ocular motor has a nerve, which is very cool as well if you want to identify it, passes between posterior cerebral and superior cerebellar. What is posterior cerebral artery supplying? The primary visual cortex. And superior cerebellar, it's enough for me if you just say the cerebellum. We've done ocular motor, the venous sinuses. You actually know what the cavernous sinus, Dr. Cooper would have mentioned the cavernous sinus, right? He did the sinuses, right? Kind of, yes? Hope so. Said he did. All right. Now, last but not least is one little nerve there. One tiny, delicate little nerve. Trochlear. Think about it. Trochlear is doing only one thing. Innervating the superior oblique muscle. So it's tiny to begin with. Now, and it's long. And why do I say long? It's a long nerve because, unlike ocular motor, which exits out the anterior surface of the midbrain. See that? This is anterior. So the nose is in that direction, back of the head is that way. So you can see ocular motor exiting out the anterior portion of the brainstem. In fact, here's one of these exceptions ruled. I'm only telling you because of its length. Trochlear originates all the way back here. It exits out the posterior aspect of the midbrain. And because of that, it's a very long, delicate little nerve. And because of that, it actually can be vulnerable to injury. So trochlear is a long, delicate nerve, and it's much longer than ocular motor because it's not originating on the anterior surface, but rather it exits out the brainstem from the posterior surface. So if you think it's got to loop all the way around here, and it travels along that free edge of the tentorium cerebelli along with ocular motor, and then heading to that superior orbital fissure where it enters to innervate superior oblique. So, why I like these schematics is because there's everything there, right? There's dura, there's blood vessels, there's brain anatomy, there's cranial nerves, right? Everybody's on there. And by now you should have a really good idea about all that basic anatomy. Okay, so you've done this with clinical skills. Now I think you've done this with regard to cranial nerves, talked about probably Dr. Cowie. So I'm not really going to go back through all this stuff again. And in fact, but it's really important that you review it. It's all clearly laid out here. Why we actually have a third nerve palsy. You've got a good idea about why the eyeball has this down and out appearance. We've got our dilated pupil. We've got our droopy eyelid, right? And then we actually have a loss of our light reflex now due to the absence of our Edinger-Westphal neurons working properly. So now one of the interesting things about these nerve palsies is the fact that they can arise from trauma, they can arise from space-occupying lesions, but don't forget, actually, there's one other primary cause of these cranial nerve neuropathies of 3, 4, and 6, and that's diabetes. Diabetic neuropathies tend to target these 3 cranial nerves, either 3, 4, or 6. And so in the absence of trauma, in the absence of a space-occupying lesion found in the brain, right, chances are, if you actually look for more diabetic cues from a chemical point of view, you may find the fact the person has just that. So you have a pretty good idea about then trochlear nerve and abducens nerve palsies. One of the things about both of them is that people will complain about double vision. And if you think about superior oblique bringing the eye in and down, one of the things that we do as human beings a lot is not that we're constantly looking down like this to see where our feet are going, but we certainly are consciously aware of where our feet are. And that, especially if you're walking down the steps I find here, where the steps are different sizes when you come to for the first time, you make the mistake, and then now I find that I'm always looking down the stairs, that when you look down, that's when superior oblique is really functional. And people will complain when superior oblique is not working, that you've got a trochlear nerve palsy. They feel very uneasy walking downstairs. That's when the double vision really kicks in. And so that's the common complaint of people who would have that trochlear nerve palsy. The only thing I want to say to you about this is that you're just aware of it, and this is just one of those intuitive things, is that you know when you ask your patient to look up, down, to the left, to the right, everything's in sync. And we're not special, right? I mean, cats do the same thing, rats do the exact same thing. I mean, how do we as mammals have this wonderful synchrony of our eyes totally together at all times? Well, it's got to be this idea of sharing information between the nuclei of our 3 cranial nerves, oculomotor, trochlear, and abducens. And there's a major pathway that actually projects among these neurons that actually interconnects them, and that's this thing called the medial longitudinal fasciculus. And this is a very heavy myelinated pathway that travels in the brainstem that interconnects our nuclei. And if you think about it, another thing that we as humans, and certainly cats and other animals can do very well, is that I can stay very focused on that clock up there, and I can tilt my head this way, and I can tilt it back that way, and my eyes stay very focused on that one particular object. It's not very difficult at all. So even though my positioning in space may change, my ability to stay focused on an object is relatively easy. And the reason for that is not only the sharing of these information among these 3 nuclei, but if you're changing the positioning of your head, right, and where you are in space even, actually now we're drawing in the vestibular apparati, right, and the vestibular nuclei within the brainstem. And so basically we get this idea of tremendous sharing of information so that vision can be purposeful exactly the way we want it. And we're not unique in this, right? I mean, if you've ever watched a cat, right, stay focused on an object, I mean, it can do that. When it's falling in space, it can turn its head around and figure out where land is. I mean, so all mammals have this. But if you just intuitively think about how do we keep our eyes in sync, and how does our brain know where we are in space and we can stay focused on an object, clearly these nuclei have to be connected. And clearly these nuclei have to be connected with the vestibular nuclei that are receiving that special sense of where we are in space. And so all of these are connected by this heavy myelinated pathway referred to as the medial longitudinal fasciculus. Great! We did it! Wow. All right. Got through it all. Well, so now what we're going to do is we're going to go through some cases. Now, have you had a chance to look at these? Oh. Nods all around the room. That's okay. So actually that's kind of cool. So now we can actually do it for the first time. All right. So what I will do is I will read the case, and then we'll go through and ask ourselves what's really important. So here we go. Case number 1. Now, remember that my cases are all about neuroanatomy being clinically relevant. Okay? I'm not a clinician. I'm not presenting things in here that are well beyond my expertise. But what I want to convey to you is the fact the anatomy I've given you is all clinically relevant. All right? That's the important thing. All right. A 61-year-old woman fell down the stairs of her home late one night. She gave herself a quick look once over, and felt no bones had been broken. She woke in the middle of the night with a severe headache over her left temple, but attributed to the hit over her head. The next morning, however, she vomited before breakfast, called her son, who soon arrived, and took her to the emergency room. The attending physician noticed that she was quite agitated. She's not quite herself. And she had a notable decrease in consciousness. In addition, we have a left dilated pupil. She had a marked right-sided hemiplegia and increased reflex responses. She was immediately sent for a CT, and the CT showed this. So we've got a major space-occupying lesion occurring on one side of the brain. Very rapidly, right? She only hit herself maybe 12 hours ago, maybe 8 hours ago. And now she's sent for a scan, and there's this thing there. Now, the great thing about these scans, now I think no one's told you yet, I want to be the first to tell you, and I'm not even a clinician. The great thing about these scans is if someone says to you, is the lesion on the left or the right? Take a moment. They're always labeled. They're always labeled left or right. So don't fall into the trap of having to know it. It's right there for you. So we see the fact the lesion is in the left side. Yet, if we go back, how does left and right work into the case? Where do we see these words? Severe headache over her left temple. When she presents in clinic, she's got left dilated pupil, but she has right-sided hemiplegia. So the right side of her body is non-functioning from a motor point of view. So we've got a left temple, we've got a left dilated pupil, and we've got a right-sided hemiplegia. Great. So, now I know Dr. Cooper did these with you. So, now this is something that occurs very rapidly over a short amount of time due to trauma. So, of those, subdural hematoma, they take a long time to develop. They're very insidious, kind of quiet, due to trauma, but take a long time. Subarachnoid hemorrhage, no. Subarachnoid hemorrhages, people literally scream out with like, this is the worst headache of my life, probably drop to their knees, and if they don't get to an emergency room soon, they will be dead. An epidural hematoma, these are due to trauma. They occur rapidly within a matter of hours. They can distort the brain, very similar to this. Meningioma is a tumor of the meninges. They take a very long time to develop. And a posterior cerebral aneurysm, well, this is not aneurysm at all. This is huge, right? So of these, the correct answer is the epidural hematoma. And she's very lucky that she actually had somebody to come get her and do this quickly. I'm not sure you remember a couple of years ago now in Canada, the actress who was skiing in Quebec, and she hit her head, and at the end of the day, and Liam Neeson's wife, can't remember her name, and hit her head, and they wanted to take her to the hospital, and she refused treatment. So none will be fine. I'm going to go sleep it off. She went to her room. The epidural hematoma developed very, very rapidly. And by the time they found her, she was non-responsive, right? Evacuated her to Montreal, much too late. So these things are growing very fast. Why are they growing fast? What's going on here? So we have to recognize the fact that these must be, something that's growing fast must be due to a pretty serious leak of blood, right? A fast leak of blood. So of these, this rapidly expanding lesion, which do you think it is? Is it due to a rupture of the middle cerebral, the posterior cerebral, superior sagittal sinus, middle meningeal, or middle cerebral? So middle cerebral is there twice, so we better actually be very careful. So does anybody have an idea about this one? Yes? Great. So why do you think that? Right, and in fact, just like the actress and just like this woman here, she's been hit on the temporal side of her head, the temple. And in fact, middle meningeal is right behind here. And so a fracture of the bone can cause a tear in this artery, which causes rapid bleeding in that epidural space. And it's under high pressure, right? So it begins to literally rip the dura away from the bone. So very, very, very fast. Now, left-sided dilated pupil. We know now about constricted and dilated pupils. If it's dilated, something's wrong with what? Which cranial nerve? Oculomotor, right? But the dilated pupil, oculomotor is not working. So we can look at all these answers here, because this is a typical Kawaja question, right? You can look at all these answers. If you know that if it's dilated, it's got to be oculomotor. You don't really have to read a lot of the other stuff going here. First of all, find that the question that's got the word oculomotor. So, postganglionic sympathetics, that's not oculomotor. Sympathetic trunk, not oculomotor. Oh, oculomotor nerve. Oh, ciliary ganglion. Well, that could be close. None of the above answers provide an adequate. Well, that's bad. So, oculomotor. Let's make sure all the answers to it are correct. A compression of the preganglionic, that's true. Parasympathetic, that's true. Axons that travel in ocular motor. Now, the next question here, next answer rather, is somewhat correct, right? The statement in here is correct. It has to do with what could be a dilated pupil, but what are the chances that there would be a compression of these tiny little axons leaving the ciliary ganglia inside the orbit? You've examined her. There's no trauma to the eye. That was never mentioned, right? So it really is this compression of the third cranial nerve. Now, why do I say that? Well, first of all, the middle meningeal artery, a little bit about it, passes through a little foramen called the foramen spinosum. The middle meningeal is found there between the bone and the dura, in that potential epidural space. And as it bleeds under high pressure, it rips the dura away from the bone, causing that expanding space-occupying lesion. Imagine this space-occupying lesion now distorting the brain. It's pushing the left side of the brain over to the right. It's displacing the brain. And the thing that you're going to see in clinical practice is a very simple observation. There is no real extra, there's a little extra space in the cranial vault. But there's no space for these occupying lesions. So they push, they distort the brain. And by distorting it, it's actually pushing down on the brainstem. Where can we actually go? And by pushing down on the brainstem, it's actually pushing little ocular motor against that pre-march of the tentorium cerebelli and pinching off the functioning of the nerves. So that's actually why we get this presentation of ocular motor not working. Ocular motor is not assessed, right? We didn't actually look so much at ocular motor, but then again, she was agitated and she was slipping out of consciousness, right? So there's probably really no time to get her to look up, look down, left and right, but the pupil was pretty obvious. But she also has some right-sided hemiplegia. Lesions on the left, right-sided hemiplegia. Why would that be? Well, we've got this expanding hematoma, that's correct. Pressing down, absolutely. What's it pressing down on? Well, it's right-sided hemiplegia. We know the space-occupying lesion is on the left, right? So chances are it's doing something on the left side. So it's pushing down on the primary motor cortex. That would be darn good as an answer. The internal capsule, that's pretty deep. Primary somatosensory cortex, well, this is about motor, the hemiplegia, nothing's working. The right primary motor cortex, no, the lesion's on the left, right? And we know that those upper motor neuron axons, right, from the motor cortex, the primary motor cortex, descend through the internal capsule, get to that cervicomedullary junction where they cross the midline, right? So that's why we're having a lesion on the left presenting by an absence of motor function on the right. So absolutely, number one is the correct statement. As for the agitated state of diminished consciousness, what's likely to happen? The expanding hematoma is pressing down on the frontal lobe, thalamic nuclei, reticular formation of the midbrain, pontine nuclei, the reticular formation of the medulla. Well, that reticular formation goes with consciousness, right? But there were two parts of it, the ones in the pons, the medulla, and ones in the midbrain. So that caudal versus rostral. And it's the one in the rostral that's important for consciousness, that alertness. So again, by pushing down now on the midbrain, right? Here's our midbrain reticular formation. Neurons, you know, have this beautiful three-dimensional shape. All their synaptic inputs, right? They like to stay like that. The minute neurons get distorted, their shape is twisted and compressed, they don't work. And when you distort the formation of a neuron and it doesn't work, that's why then you have this absence of consciousness or alertness. And that's what's going on this midbrain reticular formation. So sure enough, those are our two correct answers. So you see how, just a minute. So you see how you've got a clinical presentation. The questions you've been asked are about the anatomy and how the anatomy directly relates to the clinical presentation of the patient. All right, true to my word, right? Yes. Okay, the internal capsule are as all these myelinated axons are leaving the cortex and funneling down the brain between that caudate and putamen. So if you go back and look at the caudate and putamen, there's that internal capsule, all these axons coming down en route to the brain stem and then cutting across at the cervical medullary junction. So any questions on that one? Okay. Something, just another schematic to show you about these space-occupying lesions and how they distort the brain. They're pushing it from one side onto the other. And we actually have this idea of this sort of this central herniation actually occurring here, distorting it and pushing down on the brain stem right there. So we actually can see how these space-occupying lesions cause several of these distortions. A 50-year-old man developed right-sided weakness following cardiac arrest. The patient had a history of hypertension and cigarette use, but otherwise healthy until the day of admission. Family members at the scene administered immediate CPR, oh, lucky him, which was continued by the emergency team. He was admitted to intensive care unit and was found to have rapid atrial fibrillation. I just put that in, but this is about neurosciences, right? Several days after admission, he noted to have weakness of his right hand. After a neurological consultation, the following features were found. Isolated right hand weakness of wrist flexion and extension, finger flexion, extension, abduction, adduction, as well as thumb apposition. He had intact light touch, print joint position, vibration sense was normal in the right hand. And there were no other neurological deficits noted. Just his hand is not working. All right. A CT scan, not shown, showed an area of hypodensity in a cortical region. So I'm telling you, this is not about a clinical, I'm not trying to get you to solve this problem clinically, right? I'm telling you now where the lesion has occurred. It's occurring in the cortex. Which cortical region is most likely to have this hypodensity? Now, it's important, the first word here is left and right. So we've got to go back and ask ourselves, what hand is affected? So the hand that was affected was the right hand. If we think about the right hand, right, where does it get its information from to work? Consciously work? The left cortex, right? So the first answer we're looking there is left versus right. So it's got to be left. So we've got a left precentral gyrus, a left postcentral gyrus. The precentral is the primary motor cortex, and the postcentral gyrus is the primary somatosensory cortex. This is a motor deficit. All the sensories were fine. So it's got to be that left precentral gyrus, or the primary motor cortex on the left side. An infarct of which artery is most likely to have caused this hypodensity? Now you have to think. So we know now about our homunculus. We've got our homunculus in mind. We know that what is the major artery on the cortex, right? It's that middle cerebral artery. There's a distinction between, again, left and right, so it better be the left middle cerebral artery. And we know that the middle cerebral artery has these superficial superior and superficial inferior branches. Superior going up and over the frontal cortex and the parietal cortex, and inferior going down over the temporal lobe. So we're looking for the words left, we're looking for the words middle cerebral, and then we have to think if there's some other things. So left posterior cerebral, no. The superior division of the left middle, it could be. Left anterior, no. Inferior division of left, okay. Inferior division of right, no, it can't be right, it's got to be left. So now it's this idea of, are the arteries going up and over or down and over? And we know that the primary motor cortex, already told you here, is in the frontal lobe, and they're going up and over. So, and it's important, as I've emphasized now several times, that it's critical that you recognize this general view of these vascular territories for anterior, middle, and posterior cerebral artery. And we think about the homunculus, right? We know that this is the sylvian fissure. We can find our central sulcus right there. So this is primary motor cortex. And as we come from up here, which is the leg, right, and the trunk, we come down to the arm, the hand, the face, Broca's area, right? That's about where this hypodensity would be. Small. But you cut off the blood supply to the upper motor neurons in that small area of the cortex, he can't voluntarily do the things on his hand that you ask him to do. It's not working. He looks at his hand, he wants to squeeze, make a fist, he wants to oppose his thumb, he can't do it. Because the voluntary movement of your hand starts here. You ask him the question, he can't do it. The neurons on here are deprived of blood. When they're deprived of blood, they don't work. Our lower motor neurons, right, the ones in the spinal cord innervating the skeletal muscle in your hand, they're working. They're still there. They're just not receiving the voluntary information to do the things you want them to do. So, in fact, we kind of did the case, right? We actually did it. Now this is the smallest of all the lesions we talked about. But yes, you can have these really tiny lesions where it only is affecting the hand. So the leg is unaffected, the face is unaffected. It's just the neurons innervating those lower motor neurons in the spinal cord that are responsible for driving motor activity of the limb that's affected you. So even though this schematic is showing you the entire limb, we can make the lesion even smaller, that it's just affecting the hand. Okay? So how's that one? So why is it unlikely then the internal capsule, which is this thing right here, why is it unlikely that the infarct is there? Well, if the infarct was in the internal capsule, you would have the leg affected, the arm affected, and the face affected. In fact, it's got to be in a place where we can just knock out the face. And the only place in this pathway where we can just knock out the functioning of the face is in the cortex. Because anything lower, all the axons are traveling together. And you'd never have that degree of specificity. And we know, because by the scan, there's no damage in the spinal cord, right? I told you where the damage was. So these questions are not about you, being a diagnostic clinician yet. These questions are about drawing on your knowledge of anatomy and making it clinically relevant. 46-year-old man was in a motor vehicle accident at the age of 18 years of age, sustaining a C2, C3 fractures. These fractures caused quadriparesis that gradually improved. Very lucky. In recent years, however, he has had increasing difficulty walking. He has also developed pain and numbness in the shoulders. So he's had paralysis, but now he's got some weird numbness and pain that's developing over both shoulders and radiating down the arms. More severe on the left side. So there's a little asymmetry here, but that's not the noticeable thing. He's developed, pain and numbness in the shoulders. after a thorough clinical examination, it was found he had decreased pinprick sensation, because that's pain, on the left arm from the shoulder down and over the right shoulder in a cape-like distribution. What have we seen? A cape-like distribution. Vibration sense was intact. So right off the bat, we know there's a segregation here between two systems, right? Pain and temperature from the neck down is what? Anterolateral. Proprioceptive information from the neck down is dorsal columns, medial, and meniscus. Vibration sense is intact. Pain and temperature, pain is not. Something's wrong with pain. And the distribution of the pain is in this cape-like distribution. An MR of the cervical spinal cord revealed a fluid-filled syrinx at C3 and C4. Now, these syrinxes are really nasty things for spinalized individuals. And there was a time that clinicians thought if you go in and drain them, they're actually these fluid-filled cavities. If you go in and drain them, that'll improve the prognosis for these individuals. And it's been found that it doesn't do nothing. And the really sad thing is for spinalized individuals is the fact these syrinxes will expand with time. Now, if you think about the level of the injury, if it expands downward, that's not going to make the deficit any worse, right? You already have the deficit. It's just expanding downward. But imagine for the individuals who actually have some degree of sensation of their upper arms, right? So that's been spared. And the syrinx develops upwards. It kills off neural tissue. That's bad, right? You're making their lives worse. So his neurologist diagnosed post-traumatic syringomyelia, which is a delayed sequelae of about 1% of spinal cord injury. The result is a central cord lesion. I'm telling you what it is. So we know it's a central cord lesion that gives rise to a cape-like distribution of loss of sensory function, specifically pain. And so now we have to think, so what pathways have been primarily affected by this development? So we know right off the bat, it's got to be anterolateral. It's not dorsal / posterior column, right? And it cannot be trigeminal. Because what is trigeminal associated with? The face. Right. This is of the shoulders. It can't be trigeminal. So of these two answers, then which one is the more likely? Because he presents bilaterally, I better look for something that has a bilateral component to it, rather than this one that's just saying right anterolateral. And so remember, is that the next one? Oh yeah, it is the next one. So I was going to tell you, but actually the next question. So the bilateral appearance of this loss of pain is due to the fact that what? So now we have to draw on our knowledge about that anterolateral system. So now we're only looking for one correct answer. So now there may be, right? So let's just go through it. So axons from the first order pain neurons cross the midline at the level of the spinal cord. That's false. The first order axon innervates neurons on the same side. Axons from the third order neuron innervate the contralateral somatosensory cortex. Well, that's true, but that can't be due to the bilateral appearance of the syndrome, right? Because by the time you're up in the thalamus, that's only conveying information from one side of the body. So that's not really true. That's a true statement, but it can't apply to the loss of pain. The axons from the second order neurons cross the midline at the level of spinal cord. That is true. And these are the axons that are definitely vulnerable in that central cord lesion. These axons from the second order neuron in the dorsal horn of the spinal cord that actually cross the midline in the anterior commissure to then ascend in the anterolateral systems. So let's just make sure that the other ones have nothing correct. So first order neuron, it can't be, because that only brings in things from the one side. And the axons from the second order pain neurons cross the midline to the level of the medulla as the internal arcuate fiber. So that's all wrong, right? That's true, but not for this pathway. That's true for the dorsal column, medial, and meniscus. So hopefully it's correct. Left and right anterolateral, and remembering that the central cord lesions, right, actually give rise to deficits bilaterally because of these axons crossing the midline in that anterior commissure. And if you go back to the little case, there he is with the tape-like distribution, right, due to a central cord lesioning that is knocking out those crossing axons of the anterolateral system. Regarding ascending sensory pathways, this is not even about him anymore. This is just asking you about your knowledge. So which of the following statement is incorrect? Ascending sensory pathways. The anterolateral system carries pain and information from the legs. Which one's incorrect? That's true? Pain information from the legs? Yeah, absolutely. Dorsal column medial meniscus carries fine touch from the fingertips. True. Anterolateral system carries vibration from the elbows. It's false. Vibration is dorsal columns, medial, and meniscus. Doesn't matter if we're talking about the elbow, the wrist, the knee, the ankle, right? Wrong system. Dorsal column, medial, and meniscus carries proprioceptive information from the ankle joint. True. Anterolateral system carries temperature from the hands. True. Great. A 41-year-old woman was referred to an otolaryngologist for dizziness and progressive hearing loss in the left ear. 1 year ago, the patient began to have episodes of mild dizziness, which felt like the room was spinning when she moved her head. 2 months ago, she noticed greatly reduced hearing on her left ear. In addition, she had some left facial weakness and decreased taste on the left side of her tongue. She must have been looking at this very carefully. Past history was notable for a melanoma resected from the right hip. 6 months previously with one positive lymph node. A thorough examination confirmed a unilateral hearing loss and a unilateral facial weakness. Now, we haven't done hearing too much, but where do hearing and facial function come together in one little opening inside the cranial vault? That internal acoustic meatus, right? And she's also got some really good vestibular stuff going on because she's dizzy. Wow. So maybe something's going on there. A head MRI revealed a left acoustic neuroma. So there's that nasty schwannoma again developing in the internal acoustic meatus. So I'm just giving it now, that's the anatomy. So which two nerves pass the internal acoustic meatus? And this is relevant for her condition because we know the tumor has occurred here. And hopefully of that list, you know it's facial and vestibulocochlear. We haven't done anything with hearing, but actually just let me tell you the fact that while all these things are you go through them, it's likely the fact that we actually have a problem with the sound getting from the cochlear apparatus into the brainstem itself, right? So we're actually interrupting that flow of information from the cochlea into the brainstem. So we actually have facial vestibulocochlear, and it provides a strong indication that there's a lesion outside the brainstem. Why do I say that? Just a little general rule. Hearing, once it gets into your brain, everything is shared, left and right. So there's this idea of sharing hearing. Yet you can know when there's something more in the right than the left, but hearing is an environmental thing, and it gets very much shared in the brain. So if it's very unilateral, chances are there may be damage of the cochlea itself or of the nerve bringing the information. That's a little extra because we haven't done hearing, but I just put it there. Regarding the tumor, which is likely compressing the facial and vestibulocochlear nerves, the tumor is likely to be found where? Well, where do we expect to find these? Now, this is drawing on what? Your knowledge of the relative levels of the brainstem and where you would find these nerves. And where do we find facial? What level of the brainstem do you find facial at? Pons. So, facial is not at the cervicomedullary junction, facial is not in the rostral medulla, facial is not in the midbrain, and facial is definitely not up in the thalamus, but at the level of the pons, where you find the facial colliculus. So somewhere, that's likely what the level of the tumor. Regarding the human tongue, which of the following statements is incorrect? Because she's got that weird taste thing going on. So pain from the anterior 2/3 is transmitted from the mandibular division of trigeminal, which is incorrect. That's true. Taste from the posterior 1/3 is transmitted by facial. That's false, right? The taste from the posterior 1/3 comes by glossopharyngeus.
Temperature from 1/3 of the posterior 1/3 is transmitted by glossopharyngeus. That's true. Taste from posterior 1/3 is transmitted by glossopharyngeus. That's true. And taste from the anterior 2/3 is transmitted by facial. So it's just drawing on why she had a bit of weird taste oddity going on. All right, doing well. There's 2 more to go, I think. Well, maybe it's 1 more. A 65-year-old HIV-positive man began having involuntary fleeing movements of the right arm and leg, which became progressively worse over the course of the 1 month. This made his gait and the use of his right hand quite difficult. On examination, he had continuous, wild, uncontrolled flapping and circular movements of the right arm and occasional jerky movements of the right leg with unsteady gait falling to the right. The remainder of the exam was unremarkable. Right off the bat, what does this sound like? Does this sound like ataxia? Does this sound like a hyperkinetic disorder? A hypokinetic disorder? It can't be hypo, right? Things are going crazy. Now, ataxia, right? I mean, you have that problem with gait, but ataxia, you don't have flailing limbs. You have incoordinated limbs when you're asked to do something, but you don't have flailing limbs going all over the place. Based on the observations, you are most likely to conclude he suffers from a hypokinetic disorder? No. Truncal ataxia? Well, there's something wrong with his gait, but what about with all the arms flailing around? That's not truncal ataxia. A movement disorder caused by a lesion of the primary cortex? No, that would be primary cortex on left and right. He's got a hyperkinetic disorder. That's true. And then the rest of the statement hopefully follows. Caused by a lesion of the basal ganglia. Well, hyperkinetic disorders arise from lesions of the basal ganglia. Suffers from appendicular and truncal ataxia caused by a large lesion of the cerebellum. No, because we have to be a massive lesion of the cerebellum because we have both left and right? And ataxia is predominantly termed to be a unilateral. So sounds like a hyperkinetic disorder to me. Anatomically, the most likely site. Now, look at this. You got these, and you've already said it's coming from here. So how does this link to that? So the primary lesion would be ventrolateral thalamus? No. Vermis of the cerebellum, we ruled out ataxia. Subthalamic nucleus, well, that is part of the basal ganglia. Primary motor cortex, we ruled that out. And upper cervical spinal cord? No. So some basal ganglia nucleus, and sure enough, subthalamic is right there. And we know that it's part of the basal ganglia. Given the patient's age, a lacunar infarction is given as a differential diagnosis to toxoplasmosis. You know what toxoplasmosis is? Actually, we have little parasites living in us all the time, and they can give rise to, when you actually are immunocompromised, this disease, toxoplasmosis. So he is definitely immunocompromised, right? HIV positive. Chances are he's immunocompromised. So which of these arterial systems, that's just a little bit of interesting stuff, but which of the arteries is likely to be affected that's giving blood to the basal ganglia? And of those, the only correct answer is the lenticular striates of the middle cerebral artery. All right, I think we have one more question, and then I'm done, right? Oh, good. All right. Just going to make it in time. Sorry. Okay. Oh, we're back to her. No, we're not. Different woman. She went to the chiropractor, and he did terrible things to her. Sorry. Well, I'm sorry, but it does happen. I take these out of clinical cases. Where are we going? Yeah. After a chiropractic neck manipulation, she has this list of things that has happened to her. Things are not particularly very good. And she cannot be good, because what does she have here? My goodness gracious, what doesn't she have? She has pain in the left posterior neck. She's unsteady gait, falling toward the left side. Now unsteady gait, falling toward the left. That sounds like a bit of ataxia. Left ataxia, there it is. Dizziness, nausea, decreased prick sensation over the left face, left. Decreased prick sensation of the right limbs. Well, that makes sense, because below the neck, things cross, right? Leftosis, hoarseness, due to decreased elevation of the palate and decreased gag reflex. My goodness gracious. What area would we find all these things happening in? Could it be the midbrain? Could it be the medulla? Could it be the pons? Sounds like the medulla to me, right?
Now, is it left or right? Because of the facial problem, right, it's left. She has left facial problems. She has left ataxia, right? We know left, the cerebellum, things should be on the left side, right? So chances are, because the information coming in from the face has not yet crossed the midline, it would be on the left side of the medulla. The ipsilateral loss of pain information from the face can be best explained by, again, we know that the incoming primary information is from trigeminal, and it clearly is not getting into the brain stem. It's getting stopped because there's a loss of blood supply. So pain from the ipsilateral face has nothing to do with ciliary, has nothing to do with crossing the midline, has nothing to do with the ipsilateral ventral posterior medial, and really has nothing to do with the cortex itself. We're talking about that primary sensory information not getting into the brainstem. The gag reflex and the loss of palatal elevation, we know that there's one particular nerve here that's definitely going to be affected. So we actually think about the palate and the gag reflex. We could actually say vagus. There's vagus and hypoglossopharyngeus, glossopharyngeus only, trigeminal, and facial. And the appearance of the Horner syndrome we talked about are as it compromise these descending hypothalamic inputs. So because vagus is doing a lot of things back there, it's vagus, even though you're testing for glossopharyngeus, both are affected. And the reason why we know vagus is affected, I'm sorry, it's right there. Hoarseness, right? That's vagus, right? With a decreased palatal elevation and decreased gag reflex. So the hoarseness is associated with vagus, and the decreased gag reflex, glossopharyngeus. Got through it. A bit late, but nonetheless. So I have a few scenarios that are very much like this. I'm not asking you to diagnose. I'm not asking you to come up with the answer for what's the problem. It's in there. What I want to draw on is your knowledge, what you've learned so far. Right? Now, so I realize the quiz is tomorrow. Let me turn this thing off.